Hi, my name is Noah. I'm a St. Cloud State nursing student.
And my name is Mallory. I'm a Capstone nursing student. And for the first part of our presentation, we're going to discuss the survey data that we have collected. We created an anonymous survey that was sent to all members of the emergency department staff. The purpose of the survey was to identify strengths and weaknesses when working with patients with suicidal thoughts and ideations. The first question we asked was, what is your care team role? 83% or 15 people answered that they were an RN. 5% or one person answered that they were an ED tech. 11% or two people answered that they were a nursing assistant. And 0% answered that they were a physician. Our next question was, how many patients per week do you care for with suicidal thoughts being their chief complaint for their visit? 50% of people answered that they see about 1 to 2. 45% answered that they see 3 to 5. 5% answered that they see 6 to 9, and no one answered above 10 plus people. Our next question was, on a scale of 1 to 5, how comfortable do you feel caring for suicidal patients? 33% answered that they felt very prepared and very comfortable. 28% answered that they feel prepared and comfortable. 39% answered neutral, and no one answered below neutral, which is unprepared and uncomfortable, and very unprepared and very uncomfortable. The next question was, do you feel that the DEC assessment is effective? 56% of people answered yes, 0% answered no, and 45% of people answered sometimes.
Our next question was, what tools or knowledge provided to you has been the most effective or most helpful? And we had a range of answers here, BCA classes and techniques, DEC assessments from personal experience, reflective listening is another tool, knowledge of body language was another one, education, LMS education, specifically safety protocols, and then open communication with both patients and assuming physicians. And then another question we had was, what tools or knowledge could help you and others provide better patient care? Some of the responses were compassion and sympathy, better access to social workers to coordinate care, checklists for patients who stay for longer periods of time, continued education on full suicidal assessments, more education and mental health resources in person for patients, more behavioral health beds in the ED, and education of drug addicted patients and paranoid patients. Another question we had was, what research do you want done on this topic? And I believe this was the last question we had. And the three that came up the most were safety contracts, searches of patient and patient belongings, and then opinions of or lack thereof, options, options or lack thereof options for homeless patients coming in for the mental health treatment.
So for the second portion of this presentation, we will discuss the chart review that we performed. We were given the emergency department charts for the months of July, August, and September of 2020. Within these charts, we were asked to further investigate why certain patients were never screened for suicide during triage.
Before we begin on this chart review, I did a little bit about the importance of suicidal screening in the emergency room, or really we did. The few things that we like to remember that are important about suicidal screening in patients is that the patient safety screener, the PSS-3, is the 3-question assessment used to evaluate patients' mental health and likelihood of hurting themselves. This is the thing that everyone does in the triage process. 1 in 5 people who die by suicide visit an ED in the 4 weeks prior to their death. Those who die by suicide are more likely to come into the ED with a non-psychiatric complaint than a psychiatric complaint. Screening is the first step in identifying suicidal risk, and without it, further interventions would not take place. Vulnerable populations include young adults, adolescents, veterans, those with existing mental health diagnoses, and other high stress, and those under high stress situations. Due to COVID-19, lost jobs, decreasing health, self and family, and social isolation are all factors that increase the risk of suicidal thoughts and ideation, and it's something that we all have to look into a little bit more in these times.
So we were able to go through 105 patient charts over July, August, and September of 2020 that the suicide screening was flagged as incomplete. And we found 5 common themes on which it was flagged as incomplete. So 38% of these charts were incomplete without any reason. So in most of these charts, the triage was marked as complete when it was not. So the handoff report from the triage nurse to the main nurse there might have been an error there, or there could have just been other things going on, but 38% were just done without any reason. So the second one was that they were actually completed, but the system flagged them as incomplete, and that was about 29%. In many of these cases, the questions were asked, but the system flagged the chart as if it was not done. 23% was the patient was unable to complete, and there was proper documentation of the patient was unable to complete, but the system was still flagging it as it was incomplete. 3% was an active code. The patient was an active code in which there was no documentation that the patient was unable to answer. And finally, 7% of the questions were asked, and there was a yes in one of the 3 questions, but there was no intervention documented. So the system flags it as incomplete because it thinks that there was nothing done about it.
So for recommendations for what we can do to better complete charting is to complete all 3 suicidal questions. In some of the charts that I saw, at least, and I think Mallory, you saw this too, was when some of them were answered, but then maybe 1 wasn't. And then because the system thinks that you didn't do all 3, it'll just mark the whole thing as incomplete, even though you may have asked somebody this 1 or 2 of the questions and it just didn't read it. We said do not mark triage as complete if questions were not asked. A better handoff report from the triage nurses is needed in those situations. And then if the patient answers yes to 1 of the 3 questions, make sure that they are documented. They have documented interventions and that the EMD is notified. And then in code situations, make sure that it is documented that the patient was unable to complete that assessment. Thank you so much, and thank you for listening to our presentation.
Thank you, everyone.